This is part 7 of the assessment and care of the newborn. Okay, I want to discuss the assessment of the head of the newborn. Head molding, also referred to as cone head, can be normal after birth. It goes away in about 24 to 48 hours. You will assess fontanelles and sutures. You want to observe for signs of hydrocephalus and evaluate neurologic status, such as overriding sutures, split sutures, anterior fontanelles, and posterior fontanelles. Fontanelles should be soft and flat. Full or tense is bad. Bulging is really bad. You will look at whether, we'll kind of talk about the Cephalhematoma versus Caput Succedaneum. So this image depicts overriding sutures. So we talked about Cephalhematoma versus Caput Succedaneum. Cephalhematoma is a collection of blood between the cranial, usually the parietal bone, and the periosteal membrane. In the Caput Succedaneum, it's a collection of fluid, it's dematous, and they have swelling of the scalp. On the left-hand side, you see that cephalhematoma does not cross suture lines. It appears between the first and second day and disappears after about 2 to 3 weeks or may take months. Whereas in Caput Succedaneum, it crosses the suture lines, it's present at birth or shortly thereafter, and it's usually reabsorbed within 12 hours or a few days after birth. Okay, this is an image depicting cephalhematoma. Cephalhematomas is basically, like I discussed, swelling that does not cross suture lines, disappears in about 2 weeks to 3 months. They are at a higher risk of getting jaundice. They may be unilateral or bilateral. It does not change when the baby cries, and it's usually common in vertex births. It's kind of like a giant bruise on the head. And a large cephalhematoma can actually lead to anemia and or hypotension. Okay, now I'm going to discuss Caput Succedaneum. This image depicts this. Caput results from long labor, vacuum extraction, or use of forceps during birthing process. It's swelling just beneath the scalp, which crosses suture lines. It's less serious than the cephalhematoma. The blood vessels in the head are actually compressed, which cause slow venous return. As a result, you get tissue swelling and sometimes bleeding. These go back down within a few days after birth. When looking at the face, you will assess and record facial symmetry. Some of the abnormalities can be recessed chin, broad flattened nose, or facial paralysis. So now let's review what we assess for in the eyes. Well, we want to assess for pearl pupils equal and reactive to light. You will check the eyelids for edema, eye drainage, scleral hemorrhages. Remember that the true eye color does not occur before 6 months and can still change up to 1 year. You also have to observe to make sure that there is not a blocked tear duct with eye drainage. You want to assess true blue sclera. The pediatrician will be the one that checks for the red reflex. The RN will ensure that the erythromycin eye ointment has been applied. And you will also monitor for chemical conjunctivitis. Eyelids are usually edematous after birth from birth itself. Eye color usually is set by age 3 months, but it can change up to a year. Sometimes the erythromycin eye ointment can cause some eye drainage, but that is the cause. It will clear up within a few hours after the actual application. Otherwise, the cause of the yellow-green eye goo can be from gonorrhea, chlamydia, staph, or any gram-negative bacteria. Onset for infectious eye stuff is usually after the 2nd day. Babies will usually blink in the sudden bright lights. To get them to open their eyes, turn down the lights or shade their eyes. When assessing the nose, remember, infants are nose breathers. You may have to assess nasal patency. They can smell once the nasal passages are cleared. They remove obstructions by sneezing. New babies sneeze a lot. They don't have a cold, they aren't sick, and they just have to get all that birth fluids and goo out. Babies will turn their head towards the smell of milk, whether it is breast or formula. They also react to, yucky, nasty smells like alcohol, hand gel, by turning away or blinking or desatting. When assessing the mouth, remember lips should be pink. You want to check for a cleft lip or cleft palate, or both. You want to check the sucking reflex, and you want to assess for Epstein's pearls. Um, you also will review thrush versus milk on the tongue. Epstein pearls. This is a hard white specks on the gums. They disappear on their own. These are not teeth. Some babies do have teeth when they are born, and of course, if they are loose, you want to remove them to prevent the baby from aspirating. When looking at thrush versus milk on the tongue, you could do this by wiping off the milk, but if it doesn't come off, then of course it's thrush. When assessing the ears, you want to check the cartilage status. Do they have low set ears? Are there skin tags? Do they have sinus pits? All babies should receive a hearing screen before discharge. Full-term kids should have soft and pliable pinnas that recoil when folded and released. Low set ears are characteristics of Downs and or other genetic syndromes. Usually it means that things are not okay. After the first cry, fluid from the inner ear is absorbed, so hearing is much improved. If you see the image, the top of the pinna should be parallel to the inner and outer canthus of the eye. Okay, next we're going to inspect the neck, chest, and crying. You will inspect the neck for masses, webbing, and range of motion. You will assess moral reflex for fractured clavicles or crepitus. Continue to assess for equal movement and motor activity of the arms. You'll observe for any presence of any extra nipples, prominent xiphoid process, breast hypertrophy, or symmetrical chest expansion. And remember, the cry should be loud and lusty. If a baby has a fractured clavicle, they won't move the affected side. The moral reflex will only be on the unaffected side. It is normal for babies to have slightly engorged breasts by day 3 due to mom's hormonal influence. This may last up to 2 weeks. And a high-pitched, continuous cry is common with babies that have been exposed to a maternal drug environment. Okay, quick review of the heart and lungs assessment. Assess the heart rate, the rhythm. Evaluate for murmurs, location, timing, duration. You want to examine appearance and size of the chest. Is there an unequal chest expansion? Assess the breath sounds and the respiratory effort. You want to monitor for retractions, grunting, flaring, or periodic breathing versus apnea. Evaluate the neonate's color for pallor or cyanosis. And of course, check the pulses and check the blood pressure. Remember, normal respirations are 30 to 60 breaths per minute. Normal heartbeats can be as low as 80, but up to 160 to 180. Most murmurs are transient and normal. They might need further investigation if they last past 2 days. Usually they go away after the closure of the PDA and the PFO. If baby has a murmur, check a pulse ox for a full minute. Auscultate the apical pulse for a full minute. Palpate the brachial, the femoral, and the radial pulses. Make sure they are equal and not bounding. Blood pressure. A wide difference in blood pressure in the upper and lower extremities can indicate a coarctation of the aorta. You want to check the blood pressure when they are calm and sleeping and in the right arm. Their mean should be at least their gestational age. Okay, when talking about the abdomen assessment, the abdomen appears large in relation to the pelvis. You will observe for an umbilical hernia. You will note any discharge discharge or oozing from the cord. Note if there's an appearance or amount of vessels. You will auscultate for bowel sounds. You want to palpate. It should be done softly and it should be non-tender. The appearance of the cord should be kind of whitish, gelatinous, very moist, and they should have 3 vessels present in it. The cord should stay clamped for the first 24 hours. As you see this image, it depicts an umbilical hernia. Okay, so for the assessment of the genitals, you want to examine the labia majora, the labia minora, and the clitoris. Note the size of each for gestational age during the assessment. Observe for pseudomenstruation, hypospadias versus epispadias. Do not attempt to pull foreskin back. Palpate the testes. Assess for hydrocele. Note discoloration and edema. It's common in breech births. Hypospadias is where the pee hole is on the ventral bottom surface of the penis, and epispadias is on the dorsal top surface. Make sure both testes have descended. And hydrocele is a collection of fluid in the sac around the testes. You can hold a flashlight up to it and it will actually glow. If you see a discolored or darkened scrotum, consider testicular torsion. Call a pediatrician right away. This is an emergency. So during the assessment of the anus, inspect the anal area to verify that it is patent and has no fissures. Check a rectal temp on admission to assure patency, and note passage of meconium. Okay, let's talk about the examination of extremities, especially for obvious deformities. You want to check for simian creases, polydactyl, syndactyl, club feet, or positional club feet. You want to examine more closely when the infant is reluctant to move an extremity. Note if there is a brachial palsy and or Erb's palsy. You will check for abnormal position of the legs. An infant that was born breech may have what they call, quote, breech legs. They will have uneven movements. You will assess the back and check for any neural tube defects. You will also check the tuft of the hair, caudal dimple. Okay, so positional club feet. This is when the feet are turned inward but can easily rotate straight again. It's the result of a cramped uterine environment. Brachial palsy results from damage to the brachial plexus during traumatic birth. Then you have Erb's palsy. It's most common type of brachial palsy. There's damage to the upper arm, cranial nerves 5 and 6. It can also get damage to the lower arm or whole arm. With the Erb's palsy, the arm lies limply at the side. Complete recovery is possible within a few months with minimal trauma. With severe trauma, full recovery is not likely and the arm will suffer from muscle wasting. The pediatrician usually checks for hip clicks and clunks using Barlow's maneuver, adducting the hips, and then Ortolani's maneuver. If there is a hair tuft or caudal dimple, they may need an ultrasound to rule out spina bifida. During review of the neurologic status, the nurse will evaluate the state of alertness, resting posture, the cry, muscle tone, and or motor activity. So, is the motor activity symmetrical? Is tone appropriate for gestational age? Remember, babies should not be floppy. Note if the baby has any tremors or jitteriness. Are they having any seizure activity? Remember to check common newborn reflexes. So, for a review, tremors may be due to hypoglycemia, hypocalcemia, or a substance withdrawal. If you think they're having a seizure or seizing, put your hand on the jerking extremity. If it's a seizure, it will continue jerking. If it's due to muscular immaturity, it will stop when you touch it. Seizures in babies may only be rhythmic sucking or chewing action. Sometimes they get really rigid or really floppy. They can go apneic and Brady and desat with seizures. So I'm going to talk a little bit about the common newborn reflexes. First, we have the tonic neck. You want to place the baby flat, turn their head to one side, and the extremities should straighten on that side. It may not appear in the early newborn days. The grasping reflex. Touch their palm and they will grasp your finger. Moral reflex. This is also known as startle reflex. It's elicited by loud noises or sense of being dropped. They flail their arms and flex their legs and then they cry. Rooting reflex. Touch the side of their mouth or cheek and they turn to that side to open lips to start sucking. The sucking reflex is when they suck in anything that touches their mouth or lips. Stepping reflex. Hold them upright and their legs dangle and they walk one foot in front of the other. And then we have the Babinski reflex. Run the finger along the sole of the foot and their toes will curl. This concludes part 7 of the assessment and care of the newborn.